Good evening, everyone. I would like to welcome you all on today's webinar on Art of Oncology Treatment Updates. So I welcome Dr. Kapil Goyal, sir, for the opening remarks. The stage is yours, sir. Kapil Goyal, sir.
Okay, thank you. Thank you, everyone. So, today we have gathered here to discuss the latest advances in the treatment of lung cancer. As we all know, that lung cancer is a common cause of mortality and morbidity across the world, not just in India. However, we are seeing that recent shift in the epidemiology, as in instead of squamous cell carcinoma, nowadays adenocarcinoma is becoming more and more common. Furthermore, as the treatment is shifting from histology based to the precision oncology when it is the molecular driven approach that is being used. So it is very, very important for all of us oncologists to be aware of whatever the recent advances have come in this area, particularly with the advent of immunotherapy. This area is becoming more and more complex, and we are able to offer numerous options to our patients, and hence we can improve the survival outcome of these patients as well to achieve these goals. So today we have organized this symposium, so in which I have called upon many prestigious oncologists across India to participate in this. So first, we're going to have a discussion by Dr. Aman Chaudhary, who will be discussing about CNS metastasis in EGFR mutated advanced lung cancer tumor. Followed by that, we're going to have a talk by Dr. Nitin Eshi, who will be taking in the talk in place of Dr. Shravan Dubasi. Unfortunately, Dr. Shravan Dubasi could not join today. The topic is going to be how to proceed lung biopsy, principles of molecular and biomarker analysis. After that, Dr. Rakesh Sharma will present his talk, that is the optimizing treatment in advanced EGFR mutated lung cancer. After that, Dr. Nitin Eshi will take another talk on what to physician want to know about lung cancer, because that is so much prevalent in physician community. Last but not the least, I will be taking a talk on treatment dilemma, monotherapy versus combination treatment in EGFR mutated NSCLC. So hopefully, we are going to all learn a lot and engage in the stimulating discussion. So now, first of all, I would like to call upon my first speaker, that is Dr. Aman Chaudhary. Dr. Aman Chaudhary is a consultant medical oncologist in Bharati Vidyapeeth, Pune. Topic for Dr. Aman Chaudhary is reimagining CNS mutations in EGFR mutated advanced lung cancer, how different treatment options compare. Over to you, Dr. Aman.
Yeah, thanks a lot, Dr. Kapil, for having me. So let me open my slides. Are my slides visible?
Yes, sir. Kindly make it on full screen.
Yes, just a moment. Is it full screen now? Are slides
Not now.
moving?
Yes, sir.
Chalo, okay.
Moving.
Okay, thanks a lot for having me. So today I'll be discussing reimagining CNS mutation in EGFR mutated advanced lung cancer, how treatment options compare. So talking about incidence, lung cancer, 85% of it is non-small cell lung cancer and 15% of it is small cell lung cancer. And in non-small cell lung cancer, there are gamut of mutations, including EGFR, G12C, RAS, and NTRK, ROS1, RED, LPO2. EGFR is the most common mutation, and it is seen in just a minute. And it is seen in close to 17% in Western population and close to 50 to 60% in Asian population. So incidence of EGFR, as already I have discussed, in Asia, it's close to 36 to 40%. In North America, it's close to 22 to 26%. In Russia, it's close to 18%. So there is marked geographic variation in EGFR mutation prevalence, ranging from 15% in Europe to 62% in Asia. So patients with lung cancer have the highest rates of identified brain metastasis, and such incidences are more pronounced in EGFR mutation related lung cancer. So, at a final follow-up of 44% of patients with EGFR mutated tumors had brain metastasis compared to 22% of the patient with wild type EGFR. So leptomeningeal metastasis has poor prognosis when not treated. Survival is close to 4 to 6 weeks only, and leptomeningeal metastasis may be more frequent in patients with EGFR mutated lung cancer versus those who are wild type, 9.4% versus 1.7%. So approximately 10 to 20% of non-small cell lung cancer patients have brain metastasis at the time of diagnosis, and approximately 40% will develop brain metastasis during the course of treatment. So sites of metastasis affect the quality of life. If we look, if the brain is a site of metastasis, the quality of life is the worst. And the patients with a single brain metastasis experience the greatest decline in the quality of life compared to other sites of metastasis. So, talking about brain metastasis in EGFR mutated advanced NSCLC and TKI. So, what we already know, the brain is a sanctuary site for invading metastatic tumor cells as it is protected by blood-brain barrier. Up to 40% of patients with non-small cell lung cancer with EGFR mutation will develop brain metastasis. EGFR TKIs are also substrates for human, blood-brain barrier efflux transporters to varying degrees, and this influences the distribution of compound in the brain at equilibrium. So, hence it is imperative with EGFR TKIs must have good brain exposure if they are to achieve intracranial efficacy. So osimertinib differentially penetrates the intact blood-brain barrier in monkey brain in preclinical studies. So osimertinib demonstrate higher mouse brain concentration than TKIs. We can see this in table very well. If you use a dose of 25 milligram per kg, serum concentration Cmax was 0.82, and the brain to plasma Cmax was 3.41, the highest among all the TKIs. So these study, tell us that the penetration of this osimertinib is the greatest in the brain. Osimertinib causes tumor regression in EGFR mutated brain metastasis in a mouse xenograft model, which can be seen very beautifully in this figure. And osimertinib was homogeneously distributed in all regions of the brain in healthy volunteers, which can be again be seen in this figure. So osimertinib achieves brain exposure in patients with EGFR mutated advanced non-small cell lung cancer with brain metastasis. The regional distribution and binding of osimertinib on a PET parametric image shows total volume of distribution. It shows that baseline the dose it was very less expression post 6 hours on day 2, 6 hours post ATM the single dose. It was very much in the brain. At day 22, it was seen almost entire in the entire brain. So osimertinib, few words, bind irreversibly to clinically relevant mutated EGFR form kinase like L858R exon 19 deletion T790M to selectively inhibit mutant EGFR kinase activity. It prolonged AFS and OS related to first generation EGFR TKIs, exhibited anti-tumor effects in patients with NSCLC harboring various EGFR mutations, both common and uncommon. High blood-brain barrier penetrance and brain exposure relative to other EGFR TKIs is active against CNS metastasis as well. So inhibited growth of CNS metastasis in patients with EGFR mutation positive NSCLC. So how does the efficacy of osimertinib compare to first generation TKI in the treatment of NSCLC with EGFR mutation? So looking at the FLORA trial, EGFR mutated metastatic non-small cell lung cancer, previously untreated, received osimertinib as first-line therapy. Patients with EGFR mutation were taken. Close to 995, 994 patients were enrolled. Eligible patients were randomized and were stratified based on the EGFR mutation or the race. Primary endpoint was progression-free survival. The osimertinib arm received 80 milligram per day osimertinib. The comparator arm received either erlotinib or gefitinib. So final analysis was done in the June 2019, and the majority of patients had metastatic disease, and 35% had visceral metastasis, and 21% had CNS metastasis. So if you look at the FLORA trial result, median PFS was close to 18.9 months versus 10.2 months. Median OS was close to 38.6 months versus 31.8 months. So the PFS is a direct measure of the drug benefit in patients with known or treated CNS metastasis. Median PFS was 15.2 months versus 9.6 months. Great difference. Osimertinib had significantly longer OS than compared to EGFR TKI at 24 months, 74% with osimertinib versus 59%. At 36 months, 54% versus 44% were alive. So if we look at the FLORA trial results, CNS analysis. So CNS progression events occurred in 6 versus 15% of patients receiving osimertinib. So it also had better CNS PFS. So in FLORA trial, osimertinib demonstrated a superior systemic PFS activity benefit regardless of CNS disease status at study entry versus EGFR TKIs. So if we talk about the CNS full set analysis, number of patients were 61 and 67 in both the arms. Median CNS PFS was not reached in osimertinib, and it was 14 months in in the comparator. Hazard ratio was 0.48 and CNS overall response rate was 66 versus 43%. So PFS again is a direct measure of benefit. So intracranial PFS, again we can see the curves separating very beautifully. Median CNS PFS again was not reached versus 14 months, and hazard ratio was 0.48 as I have already discussed. So FLORA results, CNS progression other than death occurred in only 12% of the patient in osimertinib and 26% in the standard TKI. So in the progression only in CNS, in the FAS, which included patients with and without CNS metastasis at trial entry, investigator assessed CNS progression events were observed in 6% of osimertinib versus 16% of the comparator arm. So patients continuing to receive first-line trial drug at 36 months, 28 versus 9 months, great difference. So first-line osimertinib may delay the need of subsequent therapies, 28% versus 9%. Continued to have received the first-line treatment trial drug at 36 months. Some real-world evidence of osimertinib with CNS metastasis, rapid intracranial response to osimertinib without radiotherapy in non-small cell lung cancer patients harboring EGFR T790 mutation, 2 case reports by Taro Yugo. And case 1, a 67-year-old woman underwent, right middle lobe resection of the lung because of an early stage NSCLC 9 years ago. Multiple nodules emerged in both lungs on CT done 7 years ago, which was recognized as recurrence. EGFR L85R mutation was positive. Gefredib was administered as first-line chemotherapy for 2 years, 11 months, and after 3 lines of cytotoxic drug regimen. Erlotinib was administered as fifth-line therapy. So which he failed in 3.5 months. 6th-line chemotherapy was then given. Spinal MRI examination detected multiple thoracolumbar metastasis. And a 7th-line, drug osimertinib was used as T790 mutation was found. And on the day 5 of administration of osimertinib was started, X-ray revealed shrinkage of pulmonary nodule, and CT image on day 13 revealed complete remission of brain metastasis except for one lesion in the left frontal lobe. So to describe the case, we have told everything. And this we can see the image after day 13. We can see multiple metastases at baseline and complete regression of those on the day 13. And again, we can see the shrinkage of the nodules in the X-ray as well. So looking at the case 2, a 76-year-old man with a 22.5 pack year smoking history underwent right upper lobe resection of the lung because of an early stage NSCLC 10 years ago, exon 19 deletion, multiple bony metastasis as recurrence emerged 6.5 years ago. Gefredib has been administered as first-line chemotherapy for 4.5 years. And afatinib was administered for 10 months after sandwiching 4 courses of carboplatin plus pemetrexed with bevacizumab. While fourth-line therapy with tegafur, gimeracil, otoracil was being administered, pleural effusion with a right-sided dominance was seen. A thoracocentesis was conducted and detected the additional T790 mutation. So osimertinib was administered as fifth-line therapy when the ECOG PS was grade of 2. So on the day 10 after administration of osimertinib was started, brain CT image revealed the remission of single brain metastatic in the right parietal lobe, which was asymptomatic. On day 14, there was decrease in pleural effusion and shrinkage of pulmonary nodules, and which was evident on X-ray. After a month, CT images revealed shrinkage of multiple lung metastasis and decrease of left-sided pleural effusion. His ECOG PS gradually improved to 1, and there was decrease in pleural effusion. Again, we can see the disappearance of brain metastasis in CT finding. Chest CT also showed shrinkage of lung metastasis. So third case report. A 74-year-old woman with a no history of smoking, elevated blood CEA levels. CT scan revealed a 40 shadow in the upper lobe of the left lung and multiple bilateral small nodules in the entire lung field, diagnosed with T4N1M1C stage 4B lung adenocarcinoma with EGFR exon 19 deletion mutation. More than 20 multiple asymptomatic brain metastasis with a maximum diameter of 12 were detected by MRI. Osimertinib ATMG was initiated as first-line therapy. WAT was deferred. So T4N1M1C stage 4B lung adenocarcinoma and multiple asymptomatic brain metastatic lesions were seen with a maximum diameter of more than 12 And after 5 weeks, the brain metastasis had disappeared completely. So again, the intracranial outcomes of de novo brain metastasis, a cohort study. So retrospective cohort study patients were selected from an institutional database. They had a diagnosis of EGFR mutant NSCLC and treated with osimertinib between 2014 and 22. Received osimertinib alone as initial therapy after first brain metastasis was diagnosed. Had at least one intact brain metastasis not previously treated with systemic or local therapy at osimertinib initiation, and had baseline brain MR before and at least one scan after osimertinib initiation. So median age was 64. Females were close to 26%. Never smokers were close to 25. ECOG PS0 was 11, and 11 plus brain metastasis were seen in 13%. So baseline scan, post 2 month scan, post 34 scan, disease control was even seen post 34 months post osimertinib. So there were 36 patients who had a median interval from brain metastasis diagnosis to first line osimertinib initiation of 25 days. In total, 136 previously untreated brain metastases were tracked from baseline, and overall 105 had complete response and 31 had partial response from baseline MRI. This reflects the objective response rate of 100%. 2-year overall survival was 80%. CNS progression rate at 1, 2, and 3 years post osimertinib were 21%, 32%, and 41% respectively. Lesion level local failure was estimated to be 0.7%, 4.7% at 1 and 2 years post osimertinib respectively. So what are the recent guidelines? So we look at the NCCN guidelines. It says if there is EGFR exon 19 deletion or IL-8 mutation, if it is found before the first line therapy, we have to start with osimertinib. If it is discovered during the systemic therapy, we may complete planned systemic therapy, including maintenance therapy, or we may interrupt and use osimertinib. So it's up to the physician's choice. Thanks a lot for patient hearing, and I'll be happy to answer if there are any questions.
Thanks a lot, Dr. Aman, for this wonderful presentation. So if there are any questions. As there are no questions, so I think we can move to our next topic. Next topic will be presented. Dr. Nitin is a consultant medical oncology in Fortis Hospital, Vasantpur. Over to you, Doctor. Is Dr. Nitin there?
I think sir is not there, sir.
Okay, so in that case, Dr. Rakesh Sharma there?
Yes, sir.
So I would like to invite Dr. Rakesh Sharma. Dr. Rakesh Sharma is consultant medical oncology with Sanar International Hospital, Gurugram, and my dear friend. Over to you, Dr. Rakesh. Can someone call Dr. Rakesh and Dr. Nitin?
Sir, I have called Rakesh sir is
Hi, Dr. Kapil, I am here.
Okay, hello. Thank you, Dr. Rakesh. Over to you.
Okay.
Rakesh. Okay. Your slide is visible, sir.
My slides are visible.
Yes, sir. Yes, sir.
Thanks for having me, Dr. Kapil. So today I will be discussing about the how to optimize treatment in advanced EGFR mutated lung cancers. So a brief about an overview of EGFR mutated positive lung cancer. So EGFR mutations are observed in approximately 40% of Asian patients and 20% of the patients with NSCLC in Asian and non-Asian population respectively. The incidence rate of EGFR mutation in Indian patient ranges from 22 to 23% as studied in various studies. EGFR mutations are located in tyrosine kinase domain and it results in increased kinase activity of EGFR leading to cell proliferation. Most common EGFR mutation is exon 19 deletion followed by exon 21 L858R point mutation. So, what is the basic difference between first, second, and third generation EGFR TKIs? So, as we all know, first generation TKIs include erlotinib, gefitinib, second generation afatinib, dacometinib, third generation osimertinib. So, first generation they inhibit EGFR reversible inhibition of both wild type and mutant EGFR. They are inactive against T790M mutation. Second generation, they inhibit EGFR irreversibly as well as their binding to ERBB2 and ERBB4 domain, and it inhibits all ERBB family signaling. So they have broader activity. They can overcome various EGFR TKI resistant mutation. About osimertinib, it also inhibit irreversibly. It has significant activity against T790M mutant EGFR and they spare wild type of EGFR. So how do osimertinib come into the first line management of EGFR mutated lung cancer? It was the FLORA trial, a phase 3 double-blind randomized trial which evaluated osimertinib versus standard of care EGFR TKI in first line management of EGFR mutant metastatic lung cancer. So we have discussed about the difference between first and second, third generation TKIs. So what is so special about this osimertinib as compared to other TKIs that it has significant ability to cross blood-brain barrier. That's why it has significant CNS activity and better CNS progression-free survival as compared to other TKIs. So it is a third generation TKI active against CNS metastasis, active against T790M resistant mutations also. So it inhibits common mutation like exon 19 deletion, L858R, T790M mutation, lower signaling, lower activity against wild type EGFR, and it crosses intact blood-brain barrier. So a brief about the FLORA study design. In this study, patients with locally advanced or metastatic NSCLC with the ECOG performance status of 0, 1, sorry, WHO performance status of 0, 1 with exon 19 deletion, L858R, no prior systemic anti-cancer therapy, no EGFR TKI therapy, stable CNS metastasis were enrolled. And stratification was done based on type of EGFR mutation as well as race. And they were randomized to osimertinib versus standard first-line EGFR TKIs. PFS was the primary endpoint. Other secondary endpoint included response rate, overall survival. So we can see that graph separated very early in the timeline with a median PFS of approximately 19 months and with osimertinib and 10.2 months with other first generation TKI. So we can see an approximately 9-month benefit of osimertinib over other TKIs. And benefit was seen across all subgroup irrespective of race, age, smoking history, CNS metastasis, type of EGFR mutation. So all subgroup derived benefit with osimertinib. In terms of overall survival, it was approximately 39 months with osimertinib and approximately 32 months with other EGFR inhibitors. It was statistically significant. Patients receiving osimertinib were more likely to be alive at second and third year landmarks. First time an EGFR TKI has translated PFS to significant OS benefit. So 28% of patients were still receiving osimertinib at the end of 3 years, which was breakthrough in metastatic lung cancer, particularly EGFR mutant lung cancer. And 22% versus 5% of the patients were still on the treatment. I have already. So moving on to time to subsequent treatment with osimertinib, it was 25.5 months. With comparator to EGFR TKI, it was approximately 14 months. So similar to PFS, benefit in terms of OS was seen in across all subgroup irrespective of stratification. So osimertinib PFS benefit was clearly maintained, consistent across all subgroups, demonstrating its superior benefit across all population, including by race, different mutation subtypes, which is important as we discuss OS subgroups. All OS subgroups showed a positive benefit in favor of osimertinib. This is consistent with PFS data, which was better with osimertinib. So why do we think osimertinib should be preferred in first-line management? So approximately 30% of all patients are eligible for osimertinib as second-line treatment for T790M mutation following progression of first or second-line TKI. So approximately 50% of the patients who are alive, just a minute, are able to get an accurate test result for T790M mutation. And this mutation and it cannot predict which patient will develop T790M mutation resistance. And some patients do not even get that far. Only 60 to 80% can receive an accurate T790M test result, not eligible for tissue biopsy, insufficient tissue, false negative on plasma test. 73 to 77% of EGFR mutant patients receive any second line therapy, either die during first line or receive only palliative care upon progression. So out of 10 patients, only 3 patients will be eligible to receive second line osimertinib. So if we see the timeline, I have highlighted, out of 10 patients, only 3 will be eligible for second line osimertinib if we use first line other first generation TKI or other TKIs. So only 3 patients will be eligible for second line osimertinib. So 60 to 79% of patients can receive accurate testing for T790 as highlighted across various studies. Not all patients are able to receive a valid T790M test result upon rebiopsy, and plasma testing may yield a false negative result. So crossover rates and subsequent second line therapies in FLORA trial also, only 31% were patients were able to receive second line therapy. Sorry, 31% patient could not receive second line therapy. 48% patient received second line therapy, out of which 29% patients were able to receive EGFR TKI other than osimertinib. 68% received cytotoxic chemotherapy and 3% other treatment, and 22% were still on osimertinib. So comparator arm was reflective of clinical practice, allowing patient with disease progression to cross over and receive osimertinib. So 30% of the patient in EGFR TKI arm could not receive second line. This represent 65% were able to receive second line therapy, out of which 47% patients were able to receive second line osimertinib, which is approximately 30%. And as mentioned earlier, out of 10, only 3 were able to receive second line osimertinib. So this is in concordance with the real life practice. And this was seen across, all trial which has used various TKI, be it first line, first generation, second generation, and third generation TKI. So in real world studies of patients with EGFR mutant NSCLC, the risk of not receiving second line therapy is very high. So this was retrospective study of patient 140 patient with EGFR mutant NSCLC in Germany. So out of 140, 130 patients were treated with first line EGFR TKI, 10 patients received first line chemotherapy, 112 patients were candidate for second line therapy. Out of 112, 34% patients, these did not receive any second line therapy. A reason for which why either patient refusal, poor PS, fast progression and death. 104 patients in this study were treated after accessibility to third generation TKI. Across all lines of therapy, only 29% were treated with third generation TKI after accessibility. So this is in concordance with the same dictum. Out of 10 patients, only 3 will be able to receive second line EGFR TKI. So real world data varies across various countries in which second line osimertinib was used. It varies from 7% from USA data to highest 36% from Singapore data. So head-to-head clinical trials of EGFR TKI are consistent with real-world data. Not all patients can receive second-line osimertinib. So talking about the survival rates, so with osimertinib, if we use it in first line, we get approximately 19 months PFS, and in second line, patient can receive chemotherapy. If we use first generation TKI, we get an approximate 10 months of PFS, and subsequently, one third patient will be detected to have T790M mutation, one third will be unknown, and out of 100, one third patient will not be able to receive any second line therapy. So if we compare, the survival is less as compared if we use osimertinib in first line. So key message here is osimertinib is the only TKI which has demonstrated significant improvement in overall survival. Flora trial was the first to demonstrate benefit of the osimertinib in terms of PFS as well as OS. OS benefit was seen in all EGFR mutation positive lung NSCLC and T790M mutant NSCLC who had progressed on first line EGFR TKI. Osimertinib is the only TKI that has statistically significant intracranial efficacy. It is well tolerated and recommended dose is 80 mg once daily. Adverse events leading to dose reduction are frequent in second generation TKI, for example, afatinib and decometinib. Sequencing cannot be considered the best strategy as almost 70% patients are not eligible to receive osimertinib in second line. So these data confirm osimertinib should be the first line standard of care for metastatic EGFR mutant NSCLC. And this is endorsed by various guidelines. This is the snapshot from the NCCN guideline, which shows that osimertinib should be the preferred EGFR inhibitory TKI for EGFR mutant NSCLC. So with this, I conclude my talk. I will be happy to answer any question.
Thank you, Dr. Rakesh, for sharing your insights. Is there any questions? As there are no questions, so I will ask Dr. Nitin to take his call. Dr. Nitin is consultant medical oncology in Fortis Hospital, Vasant Kunj. Over to you, Dr. Nitin.
Hi, good evening, everyone. Good evening, everyone. Thank you, Dr. Kapil, and also thank you to the uh, organizing team for inviting me for the session. So, since Dr. Shravan is got occupied with some urgent work, so I'll be taking two sessions. One is molecular biomarker testing in lung cancer, and another what physician should know about lung cancer. Am I audible? Hello.
Yes, sir. You are audible.
Yes, and the screen is also visible, right?
Yes, sir.
Okay, okay. So, as we discussed already, lung
You can
cancer treatment has markedly changed over the years, and now we have moved towards a targeted therapy and precision oncology in treatment of lung cancer based on the various biomarkers that are available. So, all the patients who are with lung cancer, initially metastatic setting and stage 4 diseases, we used to mainly do the biomarker testing and plan treatment according to whatever biomarker is available. But right now, even in neoadjuvant setting as well as adjuvant setting, we have significance of biomarker testing, and it does play an important role in making a wise decision on what is the best therapy that could be provided to our patients. So content would include lung cancer incidence and prevalence in India, biomarkers testing in non-small cell lung carcinoma, evolution of biomarker testing in non-small cell lung carcinoma, the past and current aspects, and key takeaways. So the burden of lung cancer in India, as per Globocan 2020, if you consider all the genders, the most common cancer is breast cancer, but lung cancer is around. It becomes is constituted on the fourth is in the fourth place among total number of cancers. And it constitutes around 5.5% of all the cancers in our country. And among males, it is the second most common cancer after head and neck, lip and oral cavity cancer, constituting around 8% of all new cases that are being diagnosed per year. So the cumulative risk is 0.67 for new cases, and the prevalence is around 5.86 per 1 lakh population. So 50% of patients with advanced non-squamous non-small cell lung carcinoma have some form of driver mutation, which are targetable. And there have been multiple drugs that have been approved on the basis of various trials that has happened over the years that led to the approval of various targetable therapies based on these biomarkers that are often seen. So the most common mutation that is being seen is EGFR mutation, which is around 17% in Western countries, but in Asian countries it is around 20 to 30%. KRAS mutation around 25%. KRAS G1C, G12C actually is 13%. ALK 7%. And there are some rare forms of EGFR mutation like exon 20 insertion. Then we have MET amplification, MET rearrangement, HER2 mutation, ROS1, BRAF, RET, NTRK, and so on. So these are a list of various drugs that are being approved on the basis of various clinical trials for each targetable biomarker. For EGFR, the frontline treatment option is osimertinib, as discussed by Dr. Rakesh, and dacomatinib, afatinib, erlotinib, and geftinib are other EGFR sensitizing targetable drugs for EGFR sensitizing mutation. For ALK mutation, the drug of choice right now is lorlatinib or brigatinib, and we can also use crizotinib, alectinib, or ceritinib. For EGFR exon 20 insertion, recently newer drugs and newer drug combinations have come up. This include a combination of amivantamab plus lazertinib, which is very good in exon 20 insertion mutations. Mobocertinib was initially approved, but then taken off because of its side effects. KRAS mutation, we have got sotorasib and adagrasib, and HER2, we have got trastuzumab deruxtecan. So the importance of biomarker testing in non-small cell lung cancer, studies have shown that patients with identified actionable mutations who receive appropriate targeted therapy have improved outcome. So as you can see from the Kaplan-Meier curve, so the blue line depicts number of patients, around 575 patients who received targeted therapy, and the red line shows those patients who never received any targeted therapy and had by standard treatment in the form of chemotherapy. So as we can see from the survival curve that there is a separation of both the curves, and the median overall survival for patients who received some form of target therapy was around 18.6 months as compared to 11.4 months in patients who never received any targeted therapy. So guidelines recommend routine biomarker testing to guide treatment decision in advanced non-small cell lung carcinoma. So this was earlier recommendation where you have to do biomarker testing only in advanced non-small cell lung carcinoma nowadays, but even in early stage cancers also we do biomarker testing because we have got adjuvant options or perioperative chemotherapy, and even neoadjuvant options for EGFR mutation are coming long way. So routine testing for molecular aberrations is recommended for all adenocarcinomas, but only in select circumstances for squamous non-small cell lung carcinoma. So for adenocarcinomas, you have to do all these molecular panels, but squamous cell carcinoma usually does not have much targetable biomarkers, and hence it's not indicated unless we don't have any available proper therapy for the patient. So for right now, as per ASCO, NCCN, ESMO, CAP, IASL, and all these guidelines, EGFR mutation is a must for all the patients with advanced non-small cell lung carcinoma, especially adenocarcinoma. So EGFR mutation, ALK rearrangement, ROS rearrangement are to be done. Along with that, BRAF mutation is also often advised. Then we have got MET exon 14 skipping mutation, RED gene fusion, NTRK gene fusion, KRAS mutation, and also PDL1. So how to test for these biomarkers? So there are multiple methods by which we can do these testing, of which one of the most sensitive method is DNA sequencing or next generation sequencing. Another method by which we can do is PCR, and for fusions, especially for exon 14 skipping mutation or ROS1 or ALK fusions, always it's better to go for an RNA sequencing panel. And we also have IHC and FISH, which are also very sensitive for many of these many of these biomarkers. So DNA sequencing, NGS and PCR can be used to detect insertions, point mutations, and deletions. So they are mainly used for EGFR, KRAS, BRAF, HER2, for MET amplification. Single gene or full gene NGS panel could be done. RNA sequencing panel, as I told, usually helps in detecting fusion abnormalities and more sensitive for ALK, ROS1, RET, and NTRK, where there is a fusion and a fusion component. IHC and FISH. FISH can be detect ALK and ROS1, highly specialized, and can provide very fast results. And IHC mainly detects ALK and ROS1. It is a very easy test. It's we can actually get the report within maybe 1 or 2 days. So, but they are not very reliable or sensitive enough to guide treatment. For ALK, it is quite sensitive, but for ROS, it's not very sensitive and often need a confirmation by NGS or FISH panel. And IHC can also be used for detecting PDL1. So evolution of biomarker testing in non-small cell lung carcinoma, past and current. So tissue journey from biopsies to analysis. So preliminary diagnosis, once you make a diagnosis, so usually we do a FNAC or a tissue biopsy. So the classic or the standard method is to do a tissue biopsy, either in the form of resection, excision biopsy, or small tissue biopsy. So if biopsy is not feasible, or if it is a only nodal disease, we might sometime has to go for a transbronchial needle aspiration, or if there is a pleural fluid or ascitic fluid, again we'll be relying upon the cytology. But the best tissue for all these biomarker testing is biopsy specimen or resection or excision specimen. And the newer method by which we can detect this circulating DNA or circulating tumor cells for further biomarker testing is by liquid biopsy. So there are three specimens, either tissue or liquid, or we can also go for cytology. So in cytology, we can use ascitic fluid, pleural fluid, sputum, maybe if say CNS mets are there, cerebrospinal fluid can be used, and all these can be used. And liquid, usually we use blood or cyst fluid. So if it is a tissue, we usually send a fresh frozen, formalin fixed paraffin embedded block for histology and cytology, from which a DNA is being extracted, and this DNA is being studied using PCR or for whole genomic sequencing, MSI, NGS, and all. And for non-cell block site, for example, if it is a fluid cytology specimen, then we usually go for a cell block we'll make a cell block, and from the cell block, we do a parallel diagnostic methods, even both in tissue biopsy as well as in cell block, we do a staining by IHC for PDL1, MMR, as well as FISH and in situ hybridization test. And for those patients for which DNA, RNA can be collected, we usually go for NGS and sequencing methods or PCR. And nowadays, there is a new technique called proteomic studies, where we use the proteins that are being produced by these cells for analyzing the major genetic changes that are being happening. So biopsy is mainly used to establish diagnosis, determine histological subtype, and biomarker testing. Histological subtyping, squamous, mainly divided into squamous or non-squamous. For biomarker testing, primary tumors and metastatic lesions are equally suitable. So to do a biomarker testing, we can go for either primary tumor or for a metastatic lesion in the primary setting. But when the disease is progressing, it's always better to go for the to get a if you want to do a resistance mutation, it's always better to do either a liquid biopsy or mutation from a metastatic site, which would be more concordant with what all genetic changes, new genetic changes that would have been acquired. So bone biopsy can be suboptimal due to decalcification and degradation of DNA, and liquid biopsies are another option where the upfront biopsy is not if the biopsy is not feasible or the site is inaccessible, then we can even go for liquid biopsies. Nowadays, there is also a concept of paired sample where we can both do a tissue biopsy and liquid biopsy together to look for evidence of any mutations. So test for EGFR, ALK, ROS1, BRAF V600E, NTRK, RET, MET exon 14 in all non-squamous NSCLC. Use broad NGS testing to detect most mutations using least amount of tissue. For squamous non-small cell lung carcinoma, consider testing in young. So in non-small cell lung carcinoma, squamous variant, usually these biomarkers are not often seen. So it has to be resorted to only those patients who are young, never and light smokers, or if biopsy specimen is of mixed histology. Now, PDL1 test can be done using IHC, and this has to be done in all non-small cell lung carcinoma in advanced stage. Completion of testing usually takes around 10 to 14 working days for biopsies. Now, ctDNA testing has the potential to be applied across all stages of non-small cell lung carcinoma and throughout the treatment pathway. Diagnosis and liquid biopsy, as I told earlier, will have either circulating free DNA or they can have circulating tumor cells. So to detect these biomarkers, we predominantly use circulating free DNAs, and this can be used at diagnostic level to make a diagnosis and what therapy to be given based on what biomarker comes out of the genetic testing. And it can also be used for monitoring prognosis as well as response to treatment and progression or relapse of disease. So some patient who is already on treatment with particular therapy, we can actually serially look for the presence of any cfDNA. And if it is present, it might show that the disease is not responding well. While the cfDNA keeps decreasing in their log value, or if it is disappearing, it means that the disease is responding to treatment. And at the same time, if the cfDNA have disappeared and on serial testing, if it reappears, it is suggestive of progression of disease or lapse of disease. ctDNA testing overcomes some major challenges associated with tissue testing because it is minimally invasive for patient, allowing for serial biopsy if needed. ctDNA in the bloodstream is comprised of DNA from all tumor sources in the body and captures both tumor heterogeneity and tumor changes over time. Now, ctDNA testing may never replace tissue biopsy entirely, but could have a complementary role to support treatment selection in patients with non-small cell lung carcinoma. Now, ctDNA may be used to detect MRD after surgery in resectable non-small cell lung carcinoma. So earlier what we told was in case of advanced stage. So in early stage lung cancer, we can also use this ctDNA or liquid biopsy to look for evidence of minimal measurable disease. So this can be usually done, especially after surgery is being completed in patient with non-small cell lung carcinoma. So after surgery, we can actually do check for a ctDNA levels. And if it is positive, then always it is indicated that we have to give some additional therapy in the form of chemotherapy, radiotherapy, immunotherapy, whatever. And if it is absent, we might be able to skip the adjuvant treatment, even though we don't have a conclusive or definitive data to skip adjuvant therapy. But if elderly patient who are not really fit for any adjuvant chemotherapy, or those who does not prefer therapy, maybe we can offer this test to look for evidence of any disease, presence of any disease or disease recurrence. So presence of MRD may be used to predict disease recurrence. Currently, MRD cannot be identified using traditional diagnostic methods. As detection of ctDNA in plasma indicates the presence of residual tumor tissue, it can be used to measure MRD. So tracer X study, 24 early stage non-small cell lung patient followed longitudinally after resection. So phylogenetically, ctDNA profiling was done, of which 93% of patients with disease recurrence were MRD positive, while 90% of patients without recurrence were MRD negative. So those patients who had MRD negative, of the 10 patients who had MRD negative, 9 of them did not have any recurrence. While of the 14 patients who were MRD positive, 13 patients did recur. So in the Tracer X study, ctDNA profiling was able to confirm MRD negativity and detect MRD in patients who relapsed before their disease was picked up by standard imaging. So liquid biopsy is coming a long way into treatment of advanced early stage of lung cancer as well. And not just lung cancer, we have got multiple cancers where this treatment modality, this diagnostic modality can be used to decide upon adjuvant therapy or for early detection of recurrence or progression of disease. Now, the comparison of tissue and liquid biopsy testing, there are similarities and differences between tumor tissue and liquid biopsy testing for molecular alteration. So tumor tissue often the problem mainly with tumor tissue that it's an invasive procedure to get a biopsy, especially in cancers like lung cancer. Either you'll have to go for a transthoracic biopsy or you'll have to go for a EBUS guided biopsy. And liquid biopsy, on the other hand, is a simple blood draw. Around 10 ml of blood has to be taken and it can be easily be processed. And repeat sampling is very difficult for tumor because you can't go ahead with if you say, tell a patient, one of your patient that after biopsy to look for other genetic alteration, you need to go for a repeat biopsy. I'm sure they'll just leave you and go to some other doctor. So serial testing is not at all possible with respect to tissue biopsy, but for liquid biopsy, it is minimally invasive, and hence we can actually do serial testing to look for response of therapy as well as to look for development of additional mutations through the course of treatment. So biology correlation with histology and cellular phenotype is possible. But in tumor tissue, the best advantage is that when you have a tissue biopsy, the proper histology could be identified and a genotypic as well as phenotypic concordance can be looked into. On the other hand, in liquid biopsy, the direct correlation between ctDNA results with histology or cell type is not possible because we only have a DNA. We only on analysis, we might understand it is a cancerous DNA only, but we won't be able to differentiate whether it is a small cell primary tumor, a small cell carcinoma, or adenocarcinoma, or squamous cell carcinoma. Squamous cell carcinoma. Sensitivity, lower tissue tumor cell content acceptable with sensitive techniques. So if you are doing NGS or other studies, tissue specimen, even smaller pieces will be enough to do the studies, while and lower tissue tumor cell content are acceptable with sensitive technique. While liquid biopsy, very sensitive method required as ctDNA may comprise less than 0.1% of cfDNA. So if you're going for a genetic study, so you have to go for a method which is very sensitive because the ctDNA often circulating tumor DNA often contains only less than 0.1% of the whole cell-free DNA. Only less than 0.1% would be ctDNA. Now, analytical standardization uses existing validated tissue processing and handling procedures, while liquid biopsy standard for analytical performance characteristic of cfDNA, ctDNA has not been well established, and there is no proper guidelines well set to recommend how a liquid biopsy performs. Whether it is well performing well or not, for a quality check point of view, we don't have a proper guideline set for liquid biopsy, and multiple labs are coming up with various liquid biopsy techniques, and we don't know how validated all these are. Evidence of clinical utility, substantial evidence for initial targeted treatment selection and subsequent treatment after targeted treatment failure in advanced non-small cell lung carcinoma. Liquid biopsy, increasing evidence are coming up, but it's not yet conclusive to make a proper decision at the upfront setting or in subsequent treatment setting. So multiple genes involved. Okay, so multiple genes are involved. So we are basically oncology, how to do the testing, whether we should go for upfront NGS testing or multiple gene testing, or whether you should rely on a reflex testing. So reflex testing means we usually do a major genes in the first go, like EGFR, ALK, ROS, and more of that. If none of them comes positive, then go for other set of genes. So that is more financially, it's quite it is more economical to go for a reflex testing. But now, since most of the NGS platforms are providing a cheaper, larger panels at a cheaper rate, so I think at upfront setting itself, you can go for a proper targeted gene panel instead of going for a reflex testing by doing a single gene testing. So in single gene testing, we'll either be doing an EGFR, ALK, and other few genes. And if EGFR is identified, we go for TKI, not identified, non-targeted treatment. ALK identified, again, Crisone. So we'll, based on the initial histology of the patient, history and characteristic of the disease, we decide upon single gene testing. This is not being followed nowadays. But on the other hand, in case of targeted panels or for next generation sequencing, we have got both targeted panels as well as for comprehensive genomic panels. We often resort to targeted panels in case of lung, which contains almost all the major genes involved. So we do a next generation sequencing. If successful test, according to what biomarker coming up, we'll add therapy accordingly. And if test results are negative, we'll go for a standard chemotherapy. So what are the advantages of NGS? NGS has a number of advantages as the number of, as compared to single gene test, as a number of clinically actionable biomarkers have increased. The ability to evaluate all non-molecular alterations in a single test has given NGS a major advantage. So if one or few molecular markers are needed, higher cost and longer turnaround time versus single gene. So nowadays turnaround time of NGS is also pretty good, even with multiple molecular markers. The only thing is that if single gene testing, if you're going for IHC or something like that, it's fine. It will be less time consuming, but otherwise single gene testing by standard methods like sequencing, it is quite time consuming, and both of these will take a while for the report to come. So it's better to resort to a multi-gene panel, so that in first go itself we'll get an idea about what are biomarkers are being tested and what are biomarkers are positive, and we can offer treatment accordingly. So if any molecular marker are needed, reduce cost, shorter turnaround time, and lower tissue requirement versus single gene. So pros of using NGS versus single gene test: NGS detects a broad range of molecular alteration in a single sample and may identify new markers that could offer additional treatment options for a patient and or provide information to help with development of a new or more effective treatment. While cons for using NGS is that high complexity of workflow that requires experienced personnel, advancement in the field of NGS are even evolving rapidly. I don't think these are major cons nowadays, because we have a lot of platforms available. A lot of companies are providing NGS panels and relatively cheaper rates. So I don't think this cons stands valid nowadays. And for NGS, I would say it's always pros, and it's better to go for NGS at the first setting itself. Techniques and molecular landscape in non-small cell lung carcinoma. Technique used following for frequently for mutation detection based on so for single gene assays cannot detect any of these. By sequencing, we can identify both single nucleotide variations and multiple ligation dependent probe amplification. That is, MLPA is needed for if there is copy number variations. MLPA is needed. Rest of the other all single nucleotide majority of changes that happens in lung cancer are single nucleotide variations. For single nucleotide variations, we can go for standard sequencing methods, either Sanger sequencing, allele specific PCR, and whatever. MLPA is needed when you are suspecting a copy number variation. And gene panel assays, we usually follows next generation sequencing, which can detect both SNVs and CNVs. And FISH is not routinely used nowadays, but if you're using FISH can detect copy number variations, but FISH does not detect single nucleotide variations. So this is a frequency of various mutations that are present, and what are tests can be used to detect each of these biomarker. We have already discussed all these elaborately. Now, EGFR mutation in lung adenocarcinoma, sample types used for EGFR mutation testing. Formalin fixed paraffin embedded sections, fresh, frozen, or alcohol fixed specimens can be used for PCR based assays. Cytology samples are also available. So for PCR as well as NGS, we often go for either tissue specimen, or we can also use the alcohol fixed specimens. Cytology samples are not suitable for EGFR mutation testing. Well, cell blocks are preferred over smears. Discordance between EGFR mutation status in primary tumor and corresponding metastatic sites are rare. Unlike the hormone receptor status in breast cancer, whereas around 15 to 20% discordance can be seen between the primary site and the metastatic site, it's not that common in patients with EGFR. So EGFR mutation test in early lung cancer. So nowadays in early lung cancer also, as I told earlier, EGFR mutation has become a standard method of detecting biomarkers in lung cancer, even in early stages. So consider adding. So NCCN also have recommended that to consider add molecular testing for EGFR mutation on diagnostic biopsy or post-surgical resection biopsy for adjuvant treatment decision for patients between stage 1B to 3A. Non-small cell lung cancer. So now advantage of NGS over PCR. One study showed that 48.6% of EGFR exon 20 insertions mutation identified by NGS are missed by PCR. So EGFR exon 19 and exon 21 mutations can easily be detected by PCR and NGS. Both are equally sensitive, relatively similar. But in case of exon 20 insertion mutations, NGS can pick much more than PCR, and around 48.6% of mutation can be identified by NGS, which might be missed by PCR. So it's almost like 50% of mutation could be missed if you resort to PCR alone. And nowadays for EGFR exon 20 insertion, we have got effective treatment strategies available, and hence it's better to go for NGS. Out of the 17 most common EGFR exon 20 insertion variants, mutation variants, only 4 can be identified via PCR. ALK rearrangement, as we discussed, ALK rearrangement can be done by FISH, it can be done by IHC, or it can also be done by sequencing. So for FISH, the false positivity rate is only 0.1%, and IHC is very less expensive and hence more widely adopted. So earlier in our in AIMS and all, we always used to follow IHC testing for ALK before NGS became very rampant. So IHC has got very good sensitivity for ALK mutation. Rose rearrangement, NSCLC, adenocarcinoma, or anything, Rose rearrangement. If the patient is EGFR positive or negative, if ALK positive, so these are usually mutually exclusive. So we look if the Rose comes out to be positive. So Rose IHC is positive, reconfirmation by a second method like FISH or another molecular assay is necessary. And Rose 1 negative, it's well and good. If Rose 1 is done by IHC. Now, if Rose 1 is done by FISH, then we have to consider reconfirmation by second method IHC or another molecular assay. So for Rose testing, a single test is not sufficient and always a second test has to be done for confirmation. Detection of elevated ROS1 protein levels by IHC may provide cost-effective screening prior to confirmatory FISH testing. So now encoded protein, RAS sends activating signals to a number of cellular pathways involved in cell proliferation and survival. Now KRAS mutations are mutually exclusive with EGFR and ALK mutation and account for nearly 30% of lung adenocarcinoma. The most common is G12C variant, which is seen in 13% of patients with lung adenocarcinoma. And that G12C, and the drugs which are available is currently we have got sotorasib that is being approved for patients with non-small cell lung carcinoma who has got G12C variant of KRAS. And KRAS mutation, single gene KRAS testing is not currently recommended, and it should always be done as a part of NGS panel. Now, BRAF mutation, more than 50% of patients will have BRAF mutation. And in non-small cell lung carcinoma, around 1 to 5% of patients have got BRAF mutation. Of the BRAF mutation, more than 50% have got BRAF V600E mutation. NGS is generally used method for detection. And if patient have BRAF V600E mutation, we can give dabrafenib plus trametinib at frontline setting for these patients. MET receptor tyrosine kinase and MET exon 14 skipping mutation in non-small cell lung carcinoma. So 3 to 4% of non-small cell lung carcinoma can have MET exon 14 skipping mutation, while 20 to 30% of sarcomatoid cancers will have MET exon skipping mutation. So MET exon skipping 14 skipping mutation is quite concordant with sarcomatoid histology, and any patient who has got sarcomatoid histology should be looked for MET exon 14 skipping mutation. Now, majority of MET exon 14 skipping mutation can be detected with DNA NGS, but increasing sensitivity with RNA NGS. So as we discussed earlier in fusion as well as exon skipping mutations and all, RNA sequencing is more sensitive than DNA sequencing. So MET exon 14 mutation detection, IHC is not recommended, FISH is not recommended, PCR is also not that sensitive. The best method is NGS, and DNA could be used, but RNA is the most sensitive method. RET receptor tyrosine kinase and RET fusions in non-small cell lung carcinoma. Again, RET fusion carcinoma is most commonly seen with papillary thyroid carcinoma. But in 1 to 2% of non-small cell, non-squamous non-small cell lung carcinoma also we can find RET fusion mutation. Majority of RET fusions can be detected by DNA NGS, but sensitivity again for fusions, RNA sequencing is better. RET fusion detection, IHC can be used, FISH can be used, DNA NGS can be used, but the most sensitive technique is RNA NGS. And majority of RET fusion can be detected with DNA NGS, but increased sensitivity with RNA NGS. Testing for NTRK fusion, again, NTRK fusion can also be done using RNA NGS is the most sensitive technique, even though we can do it by NGS as well. Reflexing to NGS versus IHC responsive for NSCLC due to low prevalence of NTRK fusion. So NTRK testing is the histological tumor type known to harbor highly recurrent NTRK fusion. Yes, go for FISH, RT-PCR or RNA sequencing. No, then you can do sequencing plating, whatever sequencing platform is available. No, then use IHC as a screening tool. No TRK expression, detection of TRK expression. Yes, then use frontline NGS, preferably with RNA testing when possible. So method for NTRK and TRK fusion, again, we can use IHC. It can provide rapid results and detect transcribed and translated events only. It is low cost also, but FISH gives rapid results, but NGS is the most sensitive method. At less depletion of tissue, fusion partner and position are identified, and RNA NGS is the most sensitive method. Only negative with NGS is a longer wait time. HER2 mutation in NSCLC, HER2 or ERBB2 present in 3 to 5% non-small cell lung carcinoma, mostly exon 20 in-frame insertions are seen. Mutually exclusive with other mutations, mostly seen in never smokers, worse overall survival than other subtypes in lung cancer mutation consortium. In non-small cell lung carcinoma, HER2 mutation and amplification must be identified using a NGS DNA panel similar to breast cancer. IHC used to assess HER2 overexpression seen in 59% of non-small cell lung carcinoma cases and 2 to 3 plus positive up to 30%. So standard method is by DNA NGS, but we can also use IHC to assess HER2 overexpression seen, which is this could be seen around 60% of non-small cell lung carcinoma cases. 2022 treatment paradigm for molecular biomarker positive advanced non-small cell lung carcinoma for EGFR classic mutations. We know we give osimertinib is the first line choice, or we can go for first generation or second generation TKI. For exon 20, we go give amivantamab plus lazertinib or amivantamab plus chemotherapy, or mobocertinib is out of the list now. And for rare mutations, we often prefer afatinib, or we can also use osimertinib. ALK mutation, the first line drug nowadays is alectinib or lorlatinib, and on progression, we can use other lines. For ROS1, crizotinib or entrectinib. For BRAF V600E, we can use dabrafenib or trametinib. For NTRK, again, entrectinib or larotrectinib. For RET, selpercatinib or pralsetinib. For MET exon 14 skipping mutation, we use capmatinib or tipotinib. KRAS G12C, we can use sotorasib on progression. First line, it is mainly chemotherapy. Follow treatment options for adenocarcinoma. PDL1 overexpression NCLC. PDL1 antibody clones can be used. So PDL1 is often done by IHC, but the platform and the antibody clone varies. For pembrolizumab, we often use DACO, and for durvalumab, we use for pembro as well as for nivolumab DACO. So DACO 22C3 is for pembrolizumab, and for 28.8 is used for nivolumab. And Ventana is mainly for durvalumab, SP263, and SP142 Ventana for atezolizumab. And the scoring is for DACO, pembrolizumab, as well as for nivolumab. We often use the TC more than or equal to 1%. Tumor proportion score is often used. While in durvalumab and again more than or equal to 25%. So PDL1 testing different antibodies used SP263. SP142, 28.8 and 22C3 are more commonly used. DACO platform 22C3 or 28.8 based on for pembrolizumab or nivolumab. A different score is adopted depending on the antibody used to detect. So biomarker for immunotherapy non-small cell lung carcinoma, a controversial topic. PDL1 is the sole current biomarker able to guide immunotherapy. But if TMB or MSI is high, also we can consider immunotherapy in patients with lung carcinoma. LAG3 is being nowadays studied in melanoma and other cancers, but lung cancer it has not come came into the guidelines or into studies. So conclusion, biomarker testing in non-small cell lung carcinoma has evolved from single gene to multiplex testing. Multidisciplinary meeting help in better understanding of sample and test requirements. Sample should obtain adequate tumor content. That is for NGS and for biomarker testing, the sample should have at least 10% of tumor content to prevent delay in processing. Ideal time for testing is 2 weeks or around 10 working days, and high throughput platforms such as NGS can be used to screen several genes at a time to provide results within the estimated time. Now, oncogenic targets and testing methodologies, in short, we have discussed all these in detail. Thank you. So if you have any question related to this topic, we can discuss that, or else I'll be moving to
Thank
the
you,
next.
Dr. Nitin, for the wonderful presentation. So it was a very nice presentation encompassing all the aspects of lung cancer detection, biopsy, and the biomolecular testing, which we all are doing. So if there are no questions, so I think we can proceed to your next talk. What the physicians want to know about lung cancer.
Yes. Mhm. So coming to the next topic, current lung cancer management, what a physician needs to know. So as we all know that oncology itself is a referral based department. And most of the cases, the first line of contact for most of the patient with cancer is a physician or a general practitioner or maybe a chest physician. So it's necessary that all the other branches of all other branches and all other specialties should know the basics about lung cancer and when to suspect lung cancer, how to suspect lung cancer, what are the basic minimum investigations that has to be done to make a diagnosis for effective treatment before, so that we can pick up the cancers at an early stage and can provide a better treatment. Uh, Better treatment, especially in this era where we are using a lot of biomarker testing and molecular studies. Earlier the patient present, it's always better to have a good prognosis. So, as I discussed earlier, Globocan data shows that lung cancer is second most common among males and it's fourth most common cancer among all the patients. And only around 14% of lung cancer in India are diagnosed at an early stage. It is very sad that we had very good healthcare system. Most of the people are educated, but still we have access to a lot of health facilities, but still only 14% of lung cancer often present at an early stage. So this has been a study which has shown that in males, around 44% of patients who present at the time of diagnosis usually have got a metastatic disease, and in females, it's a bit higher because being especially in rural India and everywhere, the females. One thing is females usually are shy, are not very comfortable coming up to doctors, or they don't share their issues with their spouse or their family. Second thing is often they are being neglected as well. Even if they have some symptoms, they might be taken to a local practitioner or an alternative medicine doctor. So most of the times the female cases, it is often present at a later stage. One is that, and second thing is in female cancers it's mostly adenocarcinoma and not often associated with smoking, so they won't be having any other respiratory complaints unless they develop a advanced stage of disease. While in case of males, usually if they are smokers, they'll have some form of chronic bronchitis or COPD, and they might be in regular treatment under a chest physician or a physician. So they are most frequently evaluated, and hence maybe that's one reason, because relatively they around 37, as we can say, around 37% of the male patients often present in loco-regional disease or 13% presenting in localized disease. So will all early detection help improve lung cancer survival? 5-year overall survival outcome decreases with increasing stage. So for stage 1, the survival 5-year overall survival is 92%, and as it grows to stage 4, it is 10% in case of lung cancer. So risk factors for lung cancer, we all know that smoking is one of the most important risk factors. Smoking is the leading cause of lung cancer. 9 out of 10 cases of lung cancer in men and 8 out of 10 cases in lung cancer in women are associated with smoking. So primary smoking is one thing, and second thing is second-hand smoking or passive smoking. If your family member or in a public place you are standing and others are smoking, there is a high chance that you will be inhaling the smoke as a second-hand smoke. Another second-hand smoke is by burning fuel at home, biomass burning at home, and all. This can also increase the risk of lung cancer. Radon gas is colorless, scentless radioactive gas that is found in houses. Radon exposure is a leading cause of lung cancer. Asbestos and other pollutants are relatively less, and these are mostly seen in occupational as an occupational hazard and often at workplaces, and can lead to increased risk of lung cancer. Radiation exposure, usually not radiation means it's not like low grade radiations. It's like radiations for treatment of other cancers. If somebody has been irradiated to the chest wall for a breast cancer, they have a risk of increasing cancer in the lung. Family history is not very strong for lung cancer, but we do nowadays find a lot of people who have got strong family history and germline mutation in certain genes like EGFR in case of lung cancer. Now, lung cancer tumor classification, as we all know, 85% are non-small cell lung carcinoma, 10 to 15% small cell lung carcinoma. Of the non-small cell lung carcinoma, 25 to 30% are squamous cell carcinoma, and 40% adenocarcinoma, 10 to 15% large cell carcinoma, and other subtypes as well. Treatment is decided based on whether lung cancer is small cell or non-small cell. That's why we mainly divide the cancer into two types: small cell lung carcinoma or non-small cell lung carcinoma. For small cell lung carcinoma, in general, present at an advanced stage of disease, they're highly responsive to first first-line chemotherapy or whatever therapy we give, but the survival in general is poor as the disease often develop resistance very fast and often grow and progress very rapidly. So small cell lung carcinoma constitutes around 13% of all lung cancers. Overall survival is around 1 year for advanced stage of disease, 7.2 months and 11.4 months. This was a data from AIMS Delhi and ADAR. So advance in treatment of small cell lung carcinoma, this is a diagram showing the evolution of various treatments. So in 1985, we started using cisplatin and etoposide combination for treatment of small cell lung carcinoma. And since then, this is the standard chemo backbone for small cell lung carcinoma. Over all these years have not changed. And the thoracic RT for that is consolidation RT for limited disease small cell lung carcinoma has been introduced in 1992. Then carboplatin and etoposide came into being, topotecan came into being, then nivolumab, and nowadays we have a surge of a lot of immunotherapy agents which has got a very good benefit in small cell lung carcinoma, mainly in the form of atezolizumab or durvalumab. So non-small cell lung carcinoma, as one case, it has got multiple histology. It could be adenocarcinoma, squamous cell carcinoma. As we discussed in the earlier slide, it has got a lot of biomarkers now available, present in these cancers. Around at least 50% of adenocarcinoma will have some form of targetable biomarker, and all these patients has to undergo biomarker testing. So advance in treatment of non-small cell lung carcinoma, early and late stage targeted and immunotherapy. Targeted therapy we already discussed in the previous session. So among immunotherapy, in 2016, pembrolizumab has been introduced into treatment of non-small cell lung carcinoma, along with chemotherapy in 2017, 2018 also in PD-L1 expression more than 1%. They have been used in both squamous as well as non-small squamous lung carcinomas. And recently in small cell lung carcinoma, there has been introduction of atezolizumab and durvalumab as well. A significant increase in approval of both targeted as well as immunotherapy in non-small cell carcinoma has been seen. One of the most important part of cancer treatment is a multidisciplinary team formation and discussion. So tumor board discussion is essential for best results for any patient because it involves multiple specialties. There will be opinions from multiple specialties, and a collaborative effort is put, and a final conclusive treatment option is being made for the patient, which is best as per his disease stage as well as his performance status, and considering his survival and longevity. So it usually for lung cancer, there should be a pulmonologist in the tumor board, radiologist, pathologist, medical oncologist, primary care physician, and cardiothoracic surgeon. So for stage 1 and 2 cancer, often limited to one lung and not involving mediastinal or more distant sites. Stage 3, where the mediastinal lymph nodes are being involved, and goal in case of early lung cancer, stage 1, 2, 3 is cure. Now, standard of care treatment for resectable non-small cell lung carcinoma is surgery with curative intent. So once the diagnosis is made, we do a multidisciplinary team discussion. If it is resectable, directly go for surgery, followed by if an indication for radio adjuvant chemotherapy, we give that. Nowadays, we have a role of perioperative chemotherapy in patients as well as neoadjuvant chemotherapy. Initially, it was neoadjuvant chemotherapy, but it's better to go for a perioperative neoadjuvant chemotherapy if there is no other targetable biomarker mutation in lung cancer, especially stage 1B to stage 3A. Unresectable, you go for a palliative treatment. Molecular testing for EGFR mutation was not routinely performed on resected tumors until recently, but since the advent of ADORA trial, where there is role of adjuvant osimertinib in treatment of EGFR mutated lung cancer, now biomarker testing is being advised in all patients who are even in a resectable stage. So what are the surgical options? Lobectomy is there. We can go for pneumonectomy, or we can go for left edge resection or segmentectomy. So outcomes in early stage lung cancer need to be improved. Surgery is the primary treatment for the patient, and adjuvant cisplatin-based chemotherapy is indicated in patients who are stage 2 or stage 3A and selected stage 1B. Basically, tumors which are more than 4 centimeter or tumors which have node positivity have to undergo adjuvant chemotherapy. Results from large randomized trial have shown that 5-year OS benefit with adjuvant platinum-based chemotherapy in patient with the lung cancer is based on the LACE meta-analysis. The OS hazard ratio is 0.89 and DFS hazard ratio is 0.84. Overall disease recurrence and deaths following surgery and adjuvant chemotherapy remain high. Even with advent of all these therapies, the recurrence rate is much high in patients with lung cancer. So localized or early stage 1B lung cancer, the 5-year recurrence rate is in the range of 45%. For stage 2, the 5-year recurrence rate is 62%, and stage 3 it is 76%. even after effective therapy. Now, as I told, as per ADORA trial, we have a role of adjuvant osimertinib to improve disease-free survival in resected EGFR mutated non-small cell lung carcinoma, stage 1B to stage 3A. This has been clearly discussed earlier in previous session by another speaker. So hence, so I'm not going to detail of that, but it has shown that both it has got DFS benefit, and recent data have shown that there is also OS benefit by using osimertinib in adjuvant setting for patients who have EGFR mutation and who have been completely resected. So it leads to 77% reduction in the risk of disease recurrence or death with osimertinib with a hazard ratio of 0.23, which is like very good. So adjuvant osimertinib provides highly effective practice-changing treatment for patients with stage 1B, 2 and 3A EGFR mutated non-small cell lung carcinoma after complete tumor resection. So if the tumor is unresectable or locally advanced cases, especially stage 3 cases when mediastinal lymph node involvement is detected, in such cases, we'll have to resort to either perioperative chemoimmunotherapy and then surgery, or we can go for definitive CT-RT. So management of adjuvant stage unresectable stage 3 non-small cell lung carcinoma, definitely a multidisciplinary team has to be there, and we have to discuss that. If it is not resectable, then we can go for definitive CRT in the standard of which is the standard of care for stage 3 unresectable non-small cell lung carcinoma. So either we can go for concurrent. So in case of definitive CTRT, we often prefer concurrent chemoradiation over sequential chemoradiation. On the other hand, adjuvant CTRT, we often prefer sequential chemoradiation where chemotherapy followed by radiation is given. But if it is definitive CTRT, we usually resort to concurrent chemoradiation. Now, survival rate remained low following CRT in unresectable stage 3 non-small cell lung carcinoma until recently. So initially, the survival rate with the even after CRT, we have seen that the survival rate still remains low for most of these patients with stage 3 and stage 4, and it usually is in 10.5 plus or minus 1 month overall survival. And OS rate following CRT, 1 year 34% only, and at 3 years it is only 9%. Less than 10% patients are surviving at 3 years following CRT in stage 3 lung cancer. Following which we have a newer trials which came up with role of using immunotherapy in adjuvant setting for treatment of stage 3 lung cancer who has been treated with definitive CTRT following the Pacific trial. Now, this is management of metastatic non-small cell lung carcinoma. Majority, around 57% of lung cancer presents at stage 4. Treatment goals, we have to improve survival, maintain and improve the quality of life, relieve the severe and debilitating symptoms, and limit adverse events. Now, current metastatic non-small cell lung carcinoma management driven by molecular testing. This has been clearly discussed earlier. Only thing is that if we don't have a targetable mutation, we'll then resort to chemoimmunotherapy if PD-L1 is high. So either we can go for a single agent PD-L1 inhibitor or PD-1 inhibitor, or we can go for a combination of PD-L1 plus CTLA inhibitor. So with chemotherapy alone, the treatment survival was 8 to 12 months only. With addition of targeted therapy, especially EGFR mutated, in FLORA trial, the survival was 38.6 months. That is around 3 years. And in Keynote 024, it was 30 months, and with PD-L1 more than 50%. Now, targeted therapy in cancer. What is targeted therapy? Targeted cancer therapy precisely identify particular cancer target. And how to identify targeted cells? We can go for molecular testing, and 50% of lung cancer will have some form of targeted agents. This has again been clearly discussed by Dr. Rakesh, the various generations of EGFR TKs which are available. But in the first line setting, we often nowadays go for osimertinib, which is a very highly potent and irreversible EGFR inhibitor. And another important thing is that it has got a very good CNS penetration, and hence it has got very trials have shown that, especially FLORA trial have shown that it has got an OS benefit, and the overall survival was around 38.6 months. Immunotherapy in cancer, immunotherapy basically enables our own immune cells to fight against cancer. And if PD-L1 is more than, if there are no driver mutations, then we have to go for immunotherapy, especially if PD-L1 is more than 50%. So if PD-L1 more than 50%, either we can resort to single agent immunotherapy, or if the tumor load is very high, we can initially start off with 4 cycles of chemotherapy, especially platinum-based chemotherapy plus immunotherapy, and then continue on immunotherapy maintenance. So more than 50%, there is an option of single agent immunotherapy in patients with lung cancer. And if PD-L1 relevant is 1 to 49%. We often combine chemotherapy with immunotherapy for the initial period, followed if there is a good response, we usually keep them in maintenance with immunotherapy. So to summarize, the overall 5-year survival in non-small cell lung carcinoma is between 10 to 15%, primarily because of majority of patient present with either locally advanced, that is stage 3, or distant metastatic stage 4 disease. Fewer diseases are diagnosed in an earlier stages. Also, as high as 30 to 60% of non-small cell lung carcinoma patient undergoing surgery eventually develop a metastatic disease. So we need to have multiple. There is scope for improvement in both neoadjuvant adjuvant setting, and we have got a lot of newer targetable agents are coming in the adjuvant setting. Like we have EGFR inhibitors already. We have trials on ALK inhibitors. We also have trials on other biomarkers for improving this survival and reducing recurrence rate for non-small cell lung carcinoma. Adjuvant osimertinib will provide a highly effective practice-changing treatment for patients with stage 1B to 3A EGFR mutated non-small cell lung carcinoma. So largest unmet need in these cases, improving the lung cancer literacy and awareness. So physicians should know what are the major symptoms of lung cancer, when to diagnose it. And also another fact that when a patient is being diagnosed with a cancer, even though stage 4, the treatment outcomes have improved so much that these physicians should know about it, and they should refer the patient promptly to a medical oncologist to start off with targeted therapy or immunotherapy or chemotherapy, and provide the best care that is being that is to be provided for the patient. Increasing access to most innovative medicines, evolving how we think about patient support to reflect increased survivorship in lung cancer, and enabling early diagnosis of lung cancer. So for general physician partner in management of lung cancer, most of the lung cancer patients are treatment are costly and time consuming. So GPs can help in counseling and decision making. And high index of suspicion is important. Optimal referral to oncologist or a pulmonologist. Brief the patient about the importance of various tests, taking care during complications and follow up and recurrence. Thank you.
Thank you so much, Dr. Nitin, for the lucid presentation. It is very, very important as the management strategies of lung cancer are changing every day. So it is important that the physicians are also well versed about especially the early diagnosis and early referral to the oncologist, so that the best management of patient can be possible. So the question that I want to ask from you is regarding the smoking suggestion. As we know that many of our patients are actually active smoker, and because of which the lung cancer happens. So what kind of advice do you employ for these patients? Like apart from the quitting smoking, is there any pharmacological method that you are employing or some counseling that you are doing for your patients to help them quit cigarette?
No. You usually, most of the patients I have seen, usually as soon as they get diagnosed with lung cancer, and especially males who are chronic smokers will have some form of breathing difficulty, COPD and all. They would have either quit the smoking, and if they have started off smoking, I do try to counsel them and make them understand that quitting smoking could have a benefit on their disease, even though it's stage 4. And if it's not possible by just counseling, then I do refer them to psychiatrist, addiction psychiatrist, who can help them with quitting smoking.
So if there are any other question with Dr. Nitin. Thank you so much, Dr. Nitin, for giving your precious time. And
Okay, thank you. Thank you
that
all.
was a very wonderful presentation. So next presentation is going to be shared by me. So host.
Sir, you are muted.
Hello. Yeah. Hi. Sorry. So since I am actually online with mobile, so can someone share the slides and I'll read out. Or just let me know if my slides are visible now.
Yes, sir.
Are they visible?
Yes, sir.
Okay. Thank you. Thank you, organizer. So topic for today that are given to me: treatment dilemma, monotherapy versus combination treatment in advanced EGFR mutated NSCLC. So the outline of presentation is going to be, first we are going to have an overview of EGFR mutated NSCLC, NSCLC, followed by what are the current recommended strategies, followed by how the combination of TKIs along with chemotherapy is going to help us in this population. So coming to the first thing, that is, as we all know and discussed by previous speakers, EGFR mutations are observed in close to 40% and 20% of the patient of NSCLC in Asian and non-Asian population respectively. So Asians have a higher percentage, that is around 40%, while the non-Asian population has lesser percent, that is 20%. The incidence rate of EGFR mutation among Indian patients we talk, so this is close to 33 to 39%. EGFR mutations are located in the tyrosine kinase domain and they result in increased kinase activity of the EGFR, leading to continued cell proliferation. If we look at about different kinds of EGFR mutation, we know that most common mutation is exon 19, that is exon 19 deletion, and second most common is exon 21, that is L858R point mutation. Rest are the less common mutation, that is the exon 12 mutation, exon 21, and exon 20 insertion mutations. If we look at the prognosis according to the stage, we know that the prognosis deteriorates steadily as the stage passes. So stage 1A, while the 5-year OS is 50%, it drops down to 36% in stage 2A, 19% in stage 3A, and in stage 4, only 2% patients survive beyond 5 years. So even in stage 1A, with the smallest of the cancer burden, where very few patients, less than maybe 10% patient, come in this stage, even in them, the overall 5-year survival remains low, that is only 50%. Now, as we have moved towards the molecular characterization of NSCLC, we have identified many mutations like EGFR, ALK, ROS1, BRAF, HER2, beta-catenin, DDR2, and MEK1, out of which it has been shown that EGFR mutation somehow gives better survival advantage. So overall survival of EGFR mutation positive patients is approximately 3.1 year, which is exactly half in patients who have EGFR mutation negative status. Now we know that how do we monitor about this and recurrence? The continual monitoring aims to stay well informed on the stage of current disease and to monitor for recurrent disease or secondary lung cancer. PET or PET-CT monitoring is done for this. Despite undergoing complete resection for the treatment of NSCLC, the lung cancer may return, that is recurrence, and it may become metastatic with multiple factors such as pre and post operative therapies and tumor location, which may all together influence the survival. Also, overall survival is not improved by early detection of recurrent NSCLC, but increased disease-free interval post-resection correlates to a higher probability of 5-year survival. If we move towards a particular EGFR mutated lung cancer, we know about osimertinib, as it has been previously discussed by various speakers, which is a third generation irreversible CNS active EGFR TKI, which was developed to selectively target both EGFR sensitizing and EGFR T790M resistant mutation. Osimertinib is selective for EGFR TKI sensitizing mutation like L858R and exon 19 detection, as well as T790M, which is prominent resistance mutation. So how it works, inhibition of EGFR mutated mutation, inhibition of T790M mutation, lower activity against wild type EGFR, and it crosses the intact blood-brain barrier, which was seen in the increased efficacy of CNS metastasis. Now, there was a concept of combining TK along with the chemotherapy, because combining cytotoxic chemotherapy with EGFR TKI, they act synergistically by inducing apoptosis and suppressing AKT and extracellular signal regulated kinase phosphorylation, which may delay resistance. Oral TKI decreases the thymidylate synthase level, which may enhance pemetrexed efficacy. So a combination of TKI along with chemotherapy is supposed to act better. There have been multiple trials where the TKI was combined along with chemotherapy and the activity was same. In this table, you can see there are multiple phase 2 and phase 3 trial. If we limit ourselves to only phase 3 trials, so there was this NEJ009 trial where pemetrexed and carboplatin were combined along with geftinib, which were compared with geftinib arm alone. In another trial by Dr. Norona, the pemetrexed carboplatin plus geftinib was compared to geftinib. It was done in Tata Memorial. Also, there were another trial by Yang et al., where the pemetrexed carboplatin, cisplatin was combined along with geftinib and comparator arm was geftinib. So all of these trials, if you look in a nutshell, so they gave a PFS advantage. PFS was almost double. So if you look at NEG 009, 11.9 months compared to 20.9 months. in Tata Memorial trial, 8 months compared to 16 months, and in Yang et al., 12.9 versus 16.9 months. So in all the trials, it showed that combination therapy increases the survival. But Geftinib is the only, or not the only drug which has been combined. Other combinations have also been tried in first-line treatment approach for EGFR mutated positive. So, if you look at the downside is that with these combination, toxicity also increases significantly. If you look at the scale of toxicity, osimertinib is the one which is the least toxic, and the trial that was done is where the Flora trial with the osimertinib with covers compare along against Geftinib or erlotinib, and the PFS was 18.9 months compared to 10.2 months. Then come the second generation EGFR inhibitor, higher toxic, that is afatinib and dacomitinib. Then we have combination of TKIs like Geftinib along with chemotherapy. The various trials have been seen, and then we have combination of erlotinib along with anti-angiogenic like bevacizumab. So all of these trial, the maximum PFS was achieved with Geftinib and carboplatin pemetrexed, which is 20.9 months, which is similar to 18.9 months, which was seen along with osimertinib alone. So if you look, so it probably osimertinib is the correct candidate to combine with the chemotherapy. If you look at how EGFR landscape has evolved over time, 1978 was the year when EGFR at a gene was identified. 2003, when the first approval of Geftinib was given in for unresectable NSCLC. In 2004, erlotinib was approved. In 2005, the first resistance mutation, that is EGFR T790M, was identified. Then there was no significant development for next 1 decade, and erlotinib and Geftinib continue to be the standard of care. In 2015, EGFR C797S mutation was reported, and along with that, the Geftinib got the regular approval. Also, 2015 was the time when osimertinib received approval for second-line uses in patient who had T790M mutation post EGFR TKI. In 2018, the dacomitinib was approved, and also this was the time when the Flora result came out and osimertinib was given approval in the first-line setting. In 2020, FDA approval was given for erlotinib plus ramucirumab as first-line therapy, and also with the ADAURA trial, osimertinib was approved as adjuvant therapy, and from 21 year onwards, the combination of TK along with chemotherapy trials are going on. Coming to the Flora data, I think the colleagues have already discussed. This was an Asian subset. If you look at particularly, the significant improvement in median PFS was seen with osimertinib arm compared to comparator EGFR TKI. If you look at the median OS, it was 38.6 months compared to 31.8 months with the comparator arm. The hazard ratio was 0.80, which was statistically significant. If you look at the median PFS, it was 16.5 months in the osimertinib arm compared to 11.0 months in the EGFR TKI comparator arm with a hazard ratio of 0.84. Oh, sorry, 0.54. If you look at all the subgroup, the consistent benefit was seen in all subgroups. Hence, the conclusion of Flora trial was that osimertinib is the only EGFR TKI which has demonstrated a clinically and statistically significant improvement in overall survival. So the Flora trial was the first to demonstrate how an EGFR TKI has translated PFS into an OS benefit. Prior to that, OS benefit was not seen. Osimertinib improved OS versus first generation EGFR TKI in untreated EGFR mutated NSCLC and T790M NSCLC that had progressed from first line EGFR TKI. Osimertinib is the only EGFR TKI to report statistically significant intracranial efficacy. Also, osimertinib is well tolerated and it is recommended at dose of 80 mg. Adverse events leading to dose reductions are frequent in the second generation EGFR TKI like afatinib and dacomitinib. Sequencing cannot be considered the best strategy as almost 70% patients are not eligible to receive osimertinib in the second line. These data together confirm osimertinib as the first line standard of care in metastatic EGFR mutated NSCLC. Osimertinib also provided unprecedented improvement in PFS in the Flora trial as seen in these figure where the first generation TKI compared with second generation to third generation. Also, if you look at the OS outcome for first-line treatment metastatic EGFR mutated NSCLC, various trials of Geftinib like IPAS and IFAM, erlotinib optimal and ensured, afatinib Lux lung trial, dacomitinib Archer trial. So all of these have been shown where the only the Flora trial, which was osimertinib, showed a significant OS benefit. Now we come to the trial that is highlight for today is the Flora 2 trial, which is a combination of osimertinib and chemotherapy. So the key inclusion criteria were patient with untreated locally advanced or metastatic EGFR mutated NSCLC. Age should have been more than 18 years with pathologically confirmed non-squamous NSCLC, either exon 19 deletion or L858R mutation, WHA performance status 0 to 1, no prior systemic therapy for advanced NSCLC, and stable serous metastases were allowed. Brain scans were done in all patients at baseline. They were stratified into two arms. The experimental arm contained standard of care osimertinib 80 mg per day, while the experimental arm consisted of osimertinib 80 mg per day. This was combined with the chemotherapy, that is pemetrexed 500 mg per meter square and carboplatin AUC 5. Uh, After 4 cycles of chemotherapy, maintenance osimertinib was given in the same dose along with pemetrexed maintenance every 3 weeks. Follow-up was done. The primary endpoint were PFS, second endpoint were DOR, DCR, HRQL, along with overall survival. If you look at the baseline characteristic in both the arms had 278 patients. The most of the patients were female, they were more than male. Average age was 61 year. Most of the patients were non-Chinese Asian. Asian population was prominent. Performance status 1 was most frequent. CNS metastasis, if you look, so 42 patients in each arm had CNS metastasis at presentation, which is significant. If you look at PFS as per investigator, median PFS was improved by 8.8 months with osimertinib. It was 25.5 months in osimertinib plus chemo arm compared to only 16.7 months in the osimertinib alone arm. Hazard ratio was 0.62, which is statistically significant. If you look at the progression-free survival as per BICR, here also we can see the PFS was improved from 19.9 months in the comparator arm to experimental arm 29.4 months. Overall maturity was 43%. If you look at PFS as per investigator across subgroup, so this combination therapy worked better in all subgroup, irrespective of sex, race, EGFR mutation type, age at screening, smoking history, EGFR mutation type, performance status, or CNS disease as well. In all of these subset, this combination was effective. If you look at patient with or without CNS metastasis, the efficacy was maintained in both. However, of course, with patient with CNS metastasis, the significance, the benefit was even more profound, where the hazard ratio was 0.47 compared to 13.8. The CNS PFS increased to 24.9 months. However, in patient who did not have any CNS metastasis, the osimertinib monotherapy was good. It was 21 months and it increased slightly to 27.6 months. Although this was also statistically significant, 0.75, but the quantum of benefit was much more in patients who had CNS metastasis. So this data suggests that in particularly in those patients who have baseline CNS metastasis, we should consider for joining chemotherapy along with osimertinib. If you look at PFS per investigator by EGFR mutation type, irrespective of exon 9 deletion as or L858R, similar quantum of benefit was seen. If you look at the acquired resistance mechanism, so various mutation like EGFR mutation, RTK mutation, MAPK, PIK3 mutation, cell cycle, and various fusion like red BRAF, it was similar in all the arms. Acquired resistance mechanism was broadly similar across treatment arm. If you look at the safety profile of combination trial, all combination trial reported high adverse event and hematological side effect across studies, that is NEJ TMH study as well as Flora 2 study. This was mainly because of the chemotherapy type. Efficacy and safety of osimertinib in clinical trial, the various trial real world data is also there. We see that the most common events are diarrhea and rash, but grade 2, grade 3 are much less. So we have newer treatment option for EGFR mutated NSCLC. In the first line, we have osimertinib coupled with chemotherapy, and amivantamab plus lazertinib Mariposa trial that has also recently presented. In second line, we have ADCs, amivantamab lazertinib if not previously used, PEM carbo chemotherapy arm, PEM carbo amivantamab, and carbo PEM amivantamab lazertinib. So we are spoiled with choices. For third line, we have amivantamab lazertinib, ADCs, PEM carbo, or third line chemo. So whatever has not been used in first line or second line, we can use in third line. Future. So now we are moving toward the era of ctDNA. So will ctDNA monitoring guide to choose better treatment option? Of course, there are data supportive of that. So there are risk adaptive trial design in which osimertinib given for 3 weeks. In patient who achieved ctDNA negativity, osimertinib was continued. While in patient who had ctDNA positivity, so they were randomized into two arms. Osimertinib was coupled with additional therapy, some kind of chemo or amivantamab, while in patient another comparator arm only osimertinib was given. So this study will answer whether high-risk patient who have ctDNA positive, whether combining some other kind of therapy with osimertinib will help. Also, it will be easier to choose patient who will have maximum benefit with this combination. The current outcome, if we look, so they have Flora trial, Flora 2 trial, Mariposa, Mariposa 2. So boundaries are getting pushed day by day. With the Flora trial, we had the new dawn in the management of NSCLC with PFS reaching to 18.9 months, which was further increased to 25.5 months with the Flora 2 trial. Mariposa has also achieved a good, that is 23.7 months. Uh, the oral regime that is there, so side effects are rash, diarrhea, paronychia. However, with the chemotherapy, carbopam and amivantamab, these are IV drugs, so likely to continue through first line treatment. The adverse event happened with them. Combination therapy, we have certain pros, that is the combining EGFR TKI with other agents such as chemotherapy, anti-angiogenic agents, or immune checkpoint inhibitors can target multiple pathways, potentially delaying or overcoming resistance. They also lead to improved outcome. Some studies have shown that combination therapies can improve overall survival and PFS compared to monotherapy. For example, combining osimertinib with bevacizumab has shown promising results. Also, they have synergistic effects with, because certain combination might have synergistic effect that enhances the efficacy of treatment beyond what each drug could achieve alone. However, there are certain cons because toxicity is increased. Combination therapies often come with increased side effects, which can affect the patient quality of life overall and require more intensive management. Also, it is complex. Managing combination therapies can be more complex, requiring careful monitoring and dose adjustment to balance efficacy and toxicity. Last but not the least, the concern is cost, because combination therapy can be significantly much more expensive, potentially limiting accessibility for some patients. If you look at the Flora versus Flora 2 trial, the treatment arm was osimertinib, where Flora 2 osimertinib coupled with chemotherapy. PFS was improved in Flora 2. Is not available for Flora 2. If you look at the CNS Mets, the PFS was 15.2 months in Flora trial. It was increased to 29.4 months in Flora 2 trial. And overall survival is not available. So we can see that the most efficacious subset is patients who have brain metastasis. Flora to summarize, osimertinib's combination with platinum and pemetrexed has demonstrated a statistically significant and clinically meaningful improvement in PFS compared to osimertinib monotherapy in patients with EGFR mutated advanced NSCLC with a hazard ratio of 0.62. In patients with CNS metastasis at baseline, osimertinib plus platinum pemetrexed reduces the risk of CNS progression or death with a higher CNS ORR and improved CNS DOR. A higher proportion of patients treated with osimertinib plus platinum pemetrexed achieve CNS CRs. The safety profiles were as expected for each treatment and were manageable with standard medical practice. The frequency and severity of AEs in the combination arm were highest during platinum-based doublet induction CT, with subsequent meaningful reduction over time. So that brings me to the end of my topic. Thank you so much for the patient listening. I'll be open to some questions if anyone has any. So, as there are no questions, so that brings us to the end of this symposium. It was a wonderful session. All of us got to learn a lot about management of metastatic NSCLC. These kind of activities are essential because we know that area of NSCLC management is undergoing rapid changes. Many drugs are coming, and many we have more and more number of therapies options available with us, and our patients need to benefit from all of that. With all that, I thank you everyone for giving their precious time to attend this symposium. Over to the organizers. Thank you.
Thank you, sir. Technical support, kindly close the meeting, please.